I first met Yahya almost 10 years ago now, and have had the pleasure to work with him on research projects, and gotten to know him quite well. And he's actually a warm member of our family, although he's met my wife but no one else. For several of our studies, we had almost weekly phone conversations that were at 7 a.m. Sydney time, 5 p.m. Maine time, and my family every time would come in, how's Yahya, how's Wes, how's all these people? So they have the names of all these people, and I've heard them talk on the telephone for a long time, but never met them. So Yahya really has done some great research and forwarded all of us in the right direction here. So it's a pleasure to have him up and talk now about some of the missing links in delirium.
My next 15 minutes or so is primarily about the exact thing that Professor Takala has brought up at the initial discussion, and I just wanted to show you this guy here. This guy had what Michael was talking about, an agitated delirium. This guy is a high-profile journalist who went in to have a laparoscopic surgery. He was told by his surgeon he'd be out of hospital in a couple of days, and then he was still in hospital 3 weeks later. He developed a substantive and prolonged episode of agitated delirium, and he was climbing beds, and then he got so upset about it that he actually wrote in the Time magazine last year describing what happened to him and saying, you know, patients should be informed better that they may actually have this. Nobody told me this before. And tonight at the dinner, we're going to have one such patient who went in to have what was described to him as a straightforward operation, and then hell broke loose. And he's here to, not to complain, but to inform what happened to him. So talking about the delirium, that's what happens in our ICUs. You know, that's what we trained for. We trained to save lives and give fluids, inotropes, rip people's gowns off, and this is what we see on the screen. We see blood pressure and heart rate and temperature and all these things that we can measure with absolute precision and certainty. But there's one thing that is completely out of the question at this time. Nobody is thinking about, you know, whether the patient is going to be delirious or not. Who cares? You know, the patient needs blood pressure, they need fluids, they need antibiotics, they need ventilation, they need this, they need that. The last thing in the minds of people is really monitoring the brain or assessing their delirium. As Michael said before, most of the delirium that occurs in ICU is a hypoactive delirium, where patients are just like almost depressed. They're just sitting there doing nothing, and a minority of them are hyperactive. They, you know, waving to you and say, "Come on, I'm delirious. Come and see me." And the others are kind of mixed. And I think the one thing that really clouded our understanding of delirium and making a diagnosis of it is the multiplicity of theories about what actually caused delirium. And you know, probably the right answer is a combination of those theories. I don't think we're any close by any stretch of an imagination, even over the 10-15 years that Richard was talking about, that we will actually pinpoint a mechanistic way of saying this is what is actually causing delirium. There's a lot of things happening at the same time, and there's a lot of interacting issues in critically ill patients that makes a singular theory almost an impossibility to think about. And when you look at the precipitating factors that may make somebody delirious or agitated, there are so many. they're the drugs that we give them, they're the intercurrent illnesses they have, the infection, the complications they may get, the surgery, the insult, the stress of surgery that they may have, the environment you put them in intensive care, they lose the time orientation, their sleep orientation, their daytime, they have catheters everywhere. The patients who we have in ICU are almost a complete set to develop agitation and delirium. Many people describe what we do to our patients as true torture. And no wonder they get all the things that they develop when in ICU in terms of getting agitated or delirious. If we just for 1 second think about delirium as an organ dysfunction in ICU and just have a comparative sort of examination of how does it stand up when we look at acute kidney injury as an organ dysfunction. I think the one thing that you will see straight away that most of the organ dysfunction that we treat in our ICU, they've been with us since the inception of intensive care. And that's what we've learned to do, and that's what we learned to treat and diagnose with a significant accuracy and precision. And we have markers, clinical markers, biomarkers, imaging markers for all of those organ dysfunction, whether it's the kidney, the lung, the heart. But when it comes to the brain or the delirium, we don't have any of that. It's relatively new to the world of intensive care. It's only about 10 years age. It comes insidiously onto you, and then you suddenly see it happening. There is no reliable biomarker that we can use, and we cannot pinpoint when it happened or when it's over. It's all a new concept that we feel very uncomfortable being a critical care physician, where we wanted to know exactly what happened, when it happened, and when it's going to be recovered. So from the survey that we've run before, it looks like we all agree that delirium is a very bad thing. We've all seen these studies, and we know that there's an independent relationship between delirium and mortality, and delirium and cognitive function down the track, and also increase in healthcare cost. So how do we monitor the delirium in our ICUs? And we saw the PAD guidelines. They've recommended 2 methods to use for delirium monitoring. They recommended the CAM ICU and the intensive care delirium checklist. And that recommendation came from realization that they're the 2 most commonly studied tools, rather than they've been the most robust or the most accurate. Both those tools were a modification of the DSM-4 and the DSM-5, which will be out next year, of the Psychiatric Association on the diagnosis of delirium. The DSM-4 talks about a disturbance of consciousness, a change in cognition, a disturbance of perceptual disturbance. It's an acute event. It's not something that people lived with for a long time. And it also, there is a preceding etiologies that is associated with the development of delirium. So if we look at how they're diagnosed, and we look at an ideal test, that ideal test should really be a highly sensitive test that we can use for screening with high accuracy. It would identify the onset and the offset of delirium, and it would correlate with the recovery of patients. It would also be something that is simple and can be done at the bedside during routine care, routine practice, and it is reproducible. When it's done by Amy, or it's done by Francis, or done by whoever, they will get the same reliability in getting the same reproducible results. That's a bit too far from what we have. And if we look at the biomarkers, I mean, this reminds me of the sepsis biomarkers, 15, 20 years ago, when all these cytokines were suddenly became sepsis biomarkers, and they were never of any help to us. And now we have, you can look at a biomarker, a bunch of biomarkers in anybody, and you will come with a trend that they're going to show some trend in some direction. This group of patients, about 100 ICU patients, they looked at their biomarkers, tried to find a correlation with their delirium, and they found that maybe IL-8 or IL-10 maybe differentiate between delirium associated with inflammation or delirium not associated with inflammation. And they came up with some fancy biomarker, the amyloid B, which correlate with the long-term cognitive dysfunction. So to cut the story shorter, the biomarkers, I think we are way behind and way away from having a biomarker to be of help for us. So we're still stuck with a clinical test that we need to do. And the clinical tests are based on an acute onset, fluctuating course, inattention, disorganized thinking, and altered level of consciousness. Both the CAM-ICU and the intensive care delirium checklist, they examine those facets to diagnose delirium. And if we look at the CAM-ICU, for example, and this is the latest way the CAM-ICU appear on the Delirium website. You go for change in mental state, and that can be simply a wandering of the RAS over the baseline. You can then test the inattention by simple letters that you ask the patients to squeeze your arm to, and then you look whether they have an altered level of consciousness, if it's anything other than a RAS of 0. And I think that's come to the question that Yuka brought in before of the relationship between the sedation level and the CAM-ICU. In the sitcom study and also in the SPARS studies, we would not do CAM-ICU unless the patient is -2 and above on the RAS scale. They need to be awake and able to conduct the test. The intensive care delirium checklist, with also Richard presented before, has multiple items. It involves no interaction with the patient. And it can be a bit more subjective rather than objective. We've asked the question, who should assess delirium? There is a couple of studies that have been done out there. One of them is done by Michael Reed, who spoke to you earlier, and that study was done at the Austin, showed that the intensive care nurses, when they looked at the diagnosis of delirium, could only diagnose 16 or to 20% of delirium that's diagnosed by a structured assessment of delirium. There was also a European study which also showed in a large multicenter study that delirium using the CAM-ICU assessed by the nurses missed 50% of delirious patient when it was assessed by the gold standard, and that's a psychosocial psychiatrist assessment. So there seemed to be a problem with the nurses doing the CAM-ICU. Whether that's a problem with the training, or a problem with the tools they use, or a problem with the components of the CAM-ICU itself, it's not really clear. But most of the studies that are out there that use CAM-ICU, most of them, apart probably from a couple of studies, came from the same group in Vanderbilt. And I think that's also probably is a significant drawback, that it hasn't come from groups other than that one group. When you look at a comparison of the delirium assessment that includes the clinician's assessment of delirium, the clinicians always do badly. Not just the nurses, but also the doctors. In this study here, they found that physicians who tried to assess delirium missed 75% of delirium that occurred in those patients when it was compared with the DSM-4 criteria. So the nurses are not doing it well, the clinicians are not doing it well. Is it the problem with the test itself, or is it a problem with the training that's been done? Now, the CAM ICU, as I said before, only done by nurses, diagnosed only 23% of the patients. And in the Dutch study, although it missed 50% of the delirium, it still showed quite a very high negative predictive value. Those patients who had a CAM ICU that's negative, in 95% of situations you could see with certainty that they are not delirious. This was a meta-analysis that was only published last night in the Critical Care Medicine, and it did look at examining the difference between CAM ICU, delirium checklist, and a couple of other delirium tools that are available. What it showed is that the tools are very specific, but they're not sensitive enough. So the specificity for the CAM ICU was significantly high and much higher than the delirium checklist, but the sensitivity of both tests are poor, although the intensive care delirium checklist was slightly more sensitive than the CAM ICU. The CAM ICU itself, it has many advantages. It's time efficient. It takes about 2 minutes to do. It's relatively simple once you trained well on it. It tests in attention and cognition, and it also improves when coupled with the RAS scale. However, it is a single time point. It fluctuates. Nature of delirium makes it harder to diagnose it with the CAM ICU all the time. It does not categorize delirium severity. It only gives you a yes or no with delirium, and it has multiple components. And again, as I said, it has low sensitivity. This is the delirium level that was done in the SPICE in Australia, New Zealand, and the delirium here was measured by the research coordinators. You can see that they managed quite well to diagnose a lot of delirium using the CAM ICU. When we did the SPICE in Malaysia, and the CAM ICU here was conducted by the nurses, they've also done quite reasonably well. They've diagnosed significantly more than what was reported in the Dutch study or in the Austin study. So maybe there is something to do with the training rather than the tool. So in summing all this together, there is a gap between the tool and the outcome of the assessment, and I think we need to look into improving the sensitivity of these tests by accepting that there is a learning curve to do these tests, that we do need to do it more so that we are a bit better in doing it, and you know, the components of the CAM ICU in particular, each component is as important as the other. We need to understand and accept that there are limitations with these tools, but so far they are the best validated clinically available tools for us. And until we get to somewhere we have a combination of tools or a combination of a tool and a biomarker, we won't be able to progress. Making it much harder is that there are a lot more missing links in delirium understanding, or delirium that the pathophysiologists are not clear. There is no direct causal link between delirium and poor outcome. It's all associations, and there is still, you know, it's hard to put a biologically plausible mechanism on how mortality, for example, will be increased from delirium. I think it is very important for us going into the future to unlock the pathophysiologic and mechanistic pathways of delirium for us to be able to find ways, either by imaging techniques or better diagnostic tools or by electrophysiology, to diagnose delirium and understand it better. This is a movie that's coming out soon in June. So the movie is called Delirium is About to Explode. This is a real movie, so make sure you go and see it. Thank you.